Hello, welcome, and welcome to the Value-Based Healthcast, brought to you each month by the Value in Health team. I'm Nick Wilkinson, a paediatrician with a special interest in setting up innovative services. Unfortunately, the lilting tones of David Hanna are not with us today. He's actually been called to the shop floor. He's got to do some work for a change, but he'll be back soon. Now, today's cast is on collaboration. So what constitutes effective collaboration? And we'll be hearing from Maynard Jones and Simon Mansfield on that. But first, I have a little story about collaboration. So I was just out and about and I met this person having a really pleasant chat. And then she starts talking enthusiastically, quite passionately about value-based healthcare. And so here she is today.
Hi, everyone.
This is Dee. Welcome. Dee is the Director of Value-Based Healthcare for CumTAF. So can you just tell us a little bit about yourself?
Yep. Hi, everybody. Nice to see so many of you here. And I shouldn't say that I'm grateful that David's not here, but it's very nice to sit in his chair. I am Head of Value-Based Healthcare at CumTAF Morgannwg University Health Board. I've been in the NHS for 26 years, including working at Welsh Government, UK policing, and in social care. And I am very enthusiastic about value-based healthcare and collaboration, so much so that for my sins, I'm now doing a doctorate in it at Swansea Value-Based Healthcare Academy. So today's topic is absolutely on point, and I'm sure you're going to enjoy the presentations today. And we've had so many questions come through from you all. So how about we kick off?
Yep, we'll kick off. And so we have Maynard Jones and Simon Mansfield. So Maynard is Associate Medical Director of Transformation at Hywel Dda, applying values-based healthcare. Her main focus is unscheduled care and MSK medicine. And with this hat on, she is National Clinical Lead for MSK and long-term arthritis. I also see that she's skilled in injury prevention. So I'm not sure there's going to be too many injuries out of this, but then also sports medicine and program director for expedition and wilderness medicine. That might be something that I'll be signing up to. Simon is head of value-based healthcare at Hywel Dda. He has extensive experience in service delivery and management across South Wales, and particularly in technology communications. And I saw security, having also had a consultant in the private sector for that. So I hope that summarises things. Welcome, guys.
Thank you so much. I really appreciate the intro, both Nick and Dee. And on the subject of collaboration, we've got a few short slides that we'd like to share with you. And we're going to do a bit of a double act between Maynard and myself. So I'll talk about the boring stuff and I'll let Maynard do the really interesting reflections a little bit later on. And I'm glad you picked up on the information security stuff, Nick. The best thing I ever did once was I unknowingly had to do a presentation on information security to the Secret Service, and I only found out that it was the Secret Service as I walked through the doors, and they took my phone apart and led me down a quiet corridor and locked the room after me. So some interesting stuff there. The subject of collaboration is one that's really close to people's hearts, and it's really important when it comes to value-based healthcare. And consequently, we're almost destined to do it a disservice in our presentation today, because the subject could probably roll on for a number of hours on the basis of the area that we've got. So we'll try and cover it and give ourselves enough time to answer the questions that have been rattling through. So I'm hoping, for starters, that technology is playing ball and you can see my screen. Lovely. In which case, I'll dive into it in the interests of time and giving ourselves enough time to talk about the subject. And some would say this is about me. It's a study in incompetence, but actually this is more about the maturity model of value-based healthcare and our journey. And that's really what I want to describe to you is our journey. And I'm sure you've all seen this model. It's that of unconscious incompetence, conscious incompetence, conscious competence, and unconscious competence. And we followed this journey, and I think our reflections on collaboration come from the journey that we've gone on as we've moved through this process. And value-based healthcare is indeed a moving and maturing model, and it's like trying to hit the moving goalposts as we go through this. And our first port of call when we started this out at stage one was I got appointed to the role and thought, how hard can it be? We'll just measure some prom data, we'll do an analysis, roll it out. Bob's your uncle, and there we go. Value-based healthcare. Well, it's not quite that easy, is it? As I'm sure we're all well aware of, it's actually quite hard. And the challenges we faced are the obvious ones. We had some challenges with our ability to collect prom data at scale, patient-reported outcome data at scale, using digital platforms. We've got a system that's driven by traditional volumetric budgetary targets that exists and has been around forever. And actually, all of the individuals that operate within that system are motivated by the targets that are within that system. And added to that, we've then baked it in over 7 decades. You've got a system that's really hard to change, and it's really hard to get people to think differently in this space. We also had some additional challenges in there. So our informatics and support services are fully committed on other targets and had no capacity to assist us. And there was this thing that was going on at the time as well of a global pandemic as we did it. All of that means that we started out from a position of not very much collaboration. It was an existential fight for survival and how we put things together. So our positioning of our formative program was that we had lots of difficult conversations, and I reflect back on those now as to why they were difficult conversations. And I suspect they were difficult because we were trying to sell something to people. We were trying to sell a concept and an approach and an idea that made sense to us. But it was apparent, it was very clearly apparent in those conversations that value was perceived poorly by people out there. It was the next shiny thing. I've heard the phrase next shiny thing so many times over the last few years, and people didn't want to invest time and effort into something that was just going to be a passing fad. And I think semantically, value has a problem. In the word value leads people down the route of cost and cost recovery and cost improvement programs. And there are some challenges that live there. And in response to that, we did the only thing that was sensible and pragmatic, and we followed the people who had enthusiasm. We followed those people who were so frustrated with the system that they were willing to take the leap and do something, anything, just to change what they were doing. And we did shamelessly leverage all of our professional and personal relationships and networks in order to try and get people on board. We also kept the value-based healthcare team small, deliberately so, and fought to do so in the face of people trying to persuade us to expand it, to avoid that perception of doing stuff to people. If we had a large monolithic team at the centre, we would then go out and do value to people, and we recognised from the outset that probably would lead us straight down the path of failure. So we kept the team really small. There were some elements that were in our favour, however. The system was already in motion, the healthcare system within Howell Health Board, due to the excellent work that had been done on the clinical strategy. And we've had superb support, it must be said, from our medical director, Professor Phil Claw, and our finance director, Professor Hugh Thomas, who have been our stalwart supporters and sponsors throughout this process. So that was the positioning. And then we get into stage 2, which is the conscious incompetence. And this is where we realise where all the gaps existed in the system. And this slide is quite boring, deliberately so, because it's the transactional nature of what we had to do at the time. We knew we had to set up the governance structures and reporting mechanisms. We knew we had to put together the programme, so we looked at the national priority areas and we linked it with our local priority areas as best we possibly could from our positions in the organisation. And we developed a business case to substantiate our value-based healthcare function, and to partner with a supplier to give us a suitable digital prom collection platform. And we put together a standard approach to service delivery. But that's kind of by the by, because what we didn't do at that point, although we started to think about it very hard, was the fact there was a low level of understanding, and consequently collaboration was very difficult across the organisation because people didn't get what value was. It didn't have a place in the organisation. It was this slightly orphaned concept, and we recognised that we needed to raise the capacity and understanding within the organisation through some sort of educational offering. Which takes us to where we are now. And I'd probably argue that we're somewhere between stages 2 and 3, which is, we're conscious, which is a good start, but we vacillate between incompetence and competence, depending on which bit of it you look at. There's some things that we've done that I think demonstrate competence, and we are definitely now capturing patient-reported outcome data at scale across our system. We're making changes to services, and they're making a difference through the lens of value, which is great. And we're building the credibility within the organisation, and hopefully beyond as well, that we can do this and we can transact operationally. We're definitely challenging the traditional systems that exist in secondary care, and we're asking the questions around why are we doing things, and how do we change. And I think that is the essence of collaboration in trying to challenge those traditional ways of thinking. And we've finally got an identity within the organisation with value. We've published our strategy and our approach to value, which is really helpfully reflected directly into our health board planning objective. So everybody understands what it is. It lives on our intranet site, and it's freely available. People can have a look at it. And not because I'm particularly intelligent, in fact, quite the converse. It's remarkably simple. It has 3 goals, and that's it. So we wanted it to be digestible for everybody. We've also got educational offerings, case studies. There's the word of mouth and the success breeding success. And I think where I get to now from the point we were at the beginning is that we have conversations rather than sales pitches. I don't feel like I'm hawking a product, and I don't feel like I'm having to change somebody's mind. We lay out the evidence, and they make an adult decision as to what they want to do about it. And I think at last as well, we're starting to progress into the area where we're joining the dots between service improvement in specific pathway areas, and starting to look a bit more into population health. So that's the quick canter through the really transactional part of our journey. And all of our reflections on collaboration stem from that journey, which is why it's important to say it. And since it's an important topic, I'm not trusted to talk about it. So I'm going to hand over to Maina for the next few slides to talk us through. So Maina, I'm hoping your microphone's working.
I'm hoping it is too. Thank you, Simon, and thanks for the introduction there. And you're doing yourself a disservice. And I think just initial reflections there, just what you're saying, is it made me think about actually. We were knocking on other people's doors at the start of this, and I think where we've come to now is others are knocking on our door, and I think that demonstrates maybe the level of maturity that we're getting to. There's still work to be done, this reflection, we talked about this following the invite, and thank you for the invite to talk about collaboration. And this, I hope, will move us nicely into some questions about where we're at. And you talked earlier there, Simon, about change, and change is hard. Change is really, really hard. People are wedded to the ways that they work. We know we're a system under constant pressure, even more so over the last couple of years. We're firefighting, and getting people to open any more tabs in their already busy mind is very, very hard. And that's probably one of the reasons people don't like change. The familiarity is much easier for them. And you mentioned earlier, it is particularly when people feel like it's being done too. What we've tried to do with our initially very small team was to try and create that space and time for people to develop the bandwidth to think beyond what's just in front of them. And value-based healthcare, we know, is about patients' journey throughout the system. And frequently we get clinicians or service delivery managers or in procurement who are looking at one small bit of that patient journey, but actually allowing them the space and capacity to be able to take that step back to look at the whole really causes some seismic shifts in the way that people think about what they're delivering and why. We talk about value-based healthcare and the value-based outcomes rather than all those traditional, I think, what did you call them, volumetric targets that we have a focus on and have been driven down nationally. I know that we're very lucky. We're at a stage now where value in health nationally is really influencing national strategy, and we're hoping to see those changes come down as well. So not just a bottom up, but a top down from Welsh Government. That point there about language is key, isn't it? When we collaborate, we each come from different parts of the system and the service. And I know there's some questions that have come in from different industries and partners, and the language that we bring in is often very different. So how do we develop a shared language? And that is about that developing of a shared purpose and understanding that, we as a small team were having to become multilinguists and translators, really, to support people across the system to develop that shared purpose. And that is key, and people's understanding changes as well. So it's being cognizant of that and providing that space, that safe space for people to develop it in their own time. And that obviously that does inform your conversation and the richness of conversation, and that what's going on in your head. You want to get to a place where you understand what's going in the others as well. So that's seeking to understand before you start opening your mouth. That there is that thing about newness, and some people embrace it, some people don't. Some people really enjoy uncertainty, some people don't, and it's trying to understand where people are at, and there's different people that you bring into that space to collaborate to improve the outcomes for patients and patient journeys. Is understanding where they're at on that, and the sharing where we're at now in How Will I do believe is that we've got a richness of case studies to share that helps with understanding. So we're not just talking in concepts, we're talking in real-time examples, and then that can be applied to their specific areas as well. This one about thinking outward and inward is an interesting one, because I do think there's something about not invented around here that we have to be mindful of, and it is really important to learn from elsewhere. But I think there is something about, actually there's a lot of assets within our systems and within our services that we've got to celebrate as well. So I think it's about developing a healthy balance of that. This last one, I think, is really close to both our hearts, Simon. That approach to being selfless, and I think it's something about leaving the suitcase at the door. You have to kind of to collaborate with authenticity. You have to leave your ego at the door. If you believe that you've got the answer when you go in to collaborate, you're not collaborating. You're doing two. So you have to go in thinking that you don't know what the outcome is going to be, and believing you don't know what the outcome, because actually you have to work through to develop that solution together. I don't know if you want to go on to the next slide, Simon. I'll carry on talking, but it's so important, isn't it? This is just an example of one of the PROM data sets that we've got. And I don't know, Simon, if you want to talk to this. So yeah, this is absolutely, this is the voice of our patients. So this is the common language, and it is about putting the patient at the heart of everything we do. So you can come from a service level, you can come from an industry perspective, you can come from third sector. Obviously, they are speaking the language of the patient, but it's always putting the language of the patient at the heart of everything that we do. And that allows us to focus on what's important. I think a little bit more detail here about inward versus outward thinking. This is, helping us to work to patients' individual goals. So it is very much about person-centered care, and where we open our minds and embrace our vulnerabilities, and actively listen to the person that's right in front of us, the other parts of our organisation, the other sectors, and I know there's lots of different sectors on this call this afternoon, the innovation agencies, pharmaceutical companies. And I think the way the pharmaceutical companies have over more recent years collaborated with not only research, but with health and care sectors has changed as well. Their goals have changed, universities and other healthcare systems as well. This is a very important reflection, I think, for both Simon and I, that the most impressive people that we meet are the ones who don't talk about themselves or their achievements. They're the ones that go in with curiosity, understanding that they don't know, and they seek to find out, to listen, and are open to those ideas as well. Great quote. Before you criticize somebody, you should walk a mile in their shoes. That way, when you criticize them, you're a mile away from them and you have them, and you have their shoes as well. But I think the key thing is about, again, seeking to understand before you open your mouth. And I think it's very hard for people to do that. I think especially people in health. Well, I've got my own experience of, we're used to having the answers. We're used to having the solutions. It's kind of indoctrinated into us, really, to actually to live with uncertainty is very difficult as a clinician when you are expected to know the answers for your patients. Yes, just some final reflections before we go into hopefully some of the rich discussions from the questions that have been submitted. You know, for us to collectively succeed, we have to act and communicate with humility, integrity, authenticity, and credibility. No mean feat. It is really hard to do this. And again, you know, actions speak louder than words, but collaboration for me is not a noun, it's a verb. You have to act, not just talk about it. So that's it from us. I hope that gave you a bit of an insight into our journey to date, and it continues. And yeah, we'll hopefully open this out now to more discussion. So thank you very much.
Fantastic. Thank you both very much into the insightful world of the journey you've been on. And I think for me, it just shows the reflection of the maturity at the health board level, but also as we think across organisations, across other health boards who are all at different maturity levels, but also then with our partners, and as we've said, some of those that are actually joining us today. So with my hat on, I'm going to be leading us through some industry questions. As I said, we've had quite a few come through, which is fantastic. But I would just like to remind you, if you've got any more comments or any more questions, please pop them in the chat bar for us. They will be forwarded over to us, so we're hot on our phones here, so we'll keep an eye on them and we'll try and squeeze in as many as we can. But just building, so on the industry one, I know we've got some industry colleagues with us. What are your thoughts on how industry can help us co-create the solutions we need? You know, what are the things we need to bring to the table? We'll be talking about trust in a little bit, but how do we actually let other people know what we need instead of industry trying to sell us what they think we need? How do we actually co-create?
I think it's an important. There were several questions that came through from industry, and I know that we've had some discussions through our education programs and beyond as well on how we collaborate with industry. And it's historically been a bit of a dirty word, isn't it? You know, working with industry and working with private sector. But I think, you know, that has changed over recent years. And I was reflecting on, you know, some key learning I'd had with a few colleagues in this space, that actually some of the key approaches for me would apply to collaborating with anybody. And, you know, collaborating with any sector is right from the outset, you have to make sure that the decision makers are in the room from both sides, so the leaders and the implementers. Otherwise it just becomes a talking shop and you lose people very, very quickly. I think the other thing is you've got to be very clear from the outset what the scope is and the specifics and what's in and what's out. And there could be mission creep if you don't do that and are really clear about it. There's another thing about, you know, establishing regular checkpoints and check-ins, you know, so scrutiny and endorsement of actually how things are progressing, and taking time to pause and reflect on the journey that you've come on, and to celebrate successes, but also to recognize that failures are opportunities to learn. We don't like failure in healthcare for obvious reasons, but I think we have to recognize that this is about, you know, limiting and managing a risk threshold as well as we move into a bit of an unknown. So, and I think those key approaches would actually apply themselves quite nicely if you're considering outside of industry. You have to be very, very clear about the scope. And I like, you know, going back to that, collaboration is a verb, it's not a noun. You have to make sure that you've got the doers in the room, not just the talkers.
And Simon, thank you, Minute. How do we get over this issue of industry might only be in it to increase market share? How do we actually get to the real win-wins for everybody that's at the table that can actually start to get to what's going to make things better for our patients?
Thank you so much, and the question is perfect on that one. And I think the question, and it cropped up in some of the pre-asked questions as well, a fair bit I saw, was one of trust, and the importance of trust in some of those relationships. And I think that is the key. You have to have clarity on what the shared objective is, and we have to be utterly transparent in doing that. And trust is built over time, long-term relationships. And we've held on some of our education programs some discussions around industry collaborations, and it's clear that there maintains a degree of mistrust around industry and the objectives, and trying to sell product or services is clear there. And I gave an example, and if you'll permit me, I'll just very, very quickly give you the example that I gave in return, which it's a car salesman example. And if you'll excuse the context, I went to buy a car, And I went to buy a car off a forecourt, and I went in to talk to the car salesman, and I said, I'm interested in this car. It was a BMW, as it transpires. And I told him. He said, "Oh, well, what sort of mileage do you do? What's your what is it that you want the car for?" And at the time, I was making a lot of very long journeys, and he said, "You don't want this car." He said, "What you want is you want the car that all of the police services and taxi services drive. You want a Skoda Octavia." And I said, "Oh, thank you very much. That's excellent. Have you got one for sale?" No. He dissuaded me from buying a car off him to recommend me another car. As a consequence, I will forever trust that car salesman. And it's the conversations that we have that, apropos of nothing, that have no objective other than to understand the system better, are the ones that have the most power. And that was so profound that if I'm looking for a car again, I know where I'm going to. I'm going to that guy because I trust him.
Absolutely. And with the financial situation we're in at the moment, that's exactly the kind of relationships and collaboration that we're looking for with our suppliers through our procurement opportunities as well. So what do you think are some of our opportunities through procurement, and especially with our new Welsh Government Innovation Strategy in mind, that are some of the opportunities that we can work with industry in particular on as we move forward on our journey?
I think there's loads of opportunities in this space, absolutely loads of opportunities, and things like value-based procurement, where we're looking at outcomes, where outcomes are part of what we do, payment by outcomes. These sorts of things are absolutely fascinating, and they're not the absolute panacea for all ills, and I think we have to monitor them really closely to make sure that we don't game the system in a different way. But I think as long as we have honest and open partnerships, and it always, all of these conversations around procurement and collaboration for me come back to a shared objective and clarity of the shared objective. As long as we know what that is, and as long as we're all signing up to it and we operate with integrity, then you can have those situations where if there's belief in a product or a service or a technology, then we can procure on the back of it. We can drive better outcomes. So the win-win there is that there's market capitalization for the suppliers on products that really work, and we're evidencing it, and we're leveraging that to best economic effect within the health board, and we're using our public pound and our resources to better effect. So I do think there is a win-win there, and I do think that industry collaborations become increasingly important as we rely on industry partners to help us with the things that we don't have the capacity for.
Absolutely. And I think it can go a step further from our procurement as well, and actually really inform using that patient experience and the outcome measures into the R&D of organisations as well. So as we look forward, there's more opportunity for industry to be aligned to what we're finding are the real impacts on the patients of what we're purchasing. Very true. So just moving slightly on, we've had...
Can I just ask a question? Because one of the questions that was in the pre-meet was about how do you pick the right people, so, which we haven't talked about. So, you know, you've got a whole load of vendors or a whole load of people in the same space. How do you move then to find the right collaborator? Otherwise, you're collaborating with everybody, is it?
Yeah. I've got a view on this, Mina. I don't know whether you have as well. I'm happy to answer if you wish.
Yeah, you crack on. It's a difficult one. I don't think there's a one right answer, if I'm honest. Yeah.
Because I guess the question is, with all collaboration, is when do you walk away? When do you say this is the right time, this isn't the right time? Because, you know, we have to look at it in that context. And you mentioned failure. I mean, that's quite binary, isn't it? And we do think it's binary in medicine. Actually, it's learning. You know, there was a basketball star just recently put up a whole thing about they were the sort of expected to win this championship, and they lost to the underdogs. And he just said, well, we all lose, we all fail at times, but that's not failing, that's just learning. You know, we'll be back next time and better. So, you know, it's just so in terms of the collaboration, then how do you pick the people? How do you walk away? You know, do you have a feeling about that?
I think my take on this, and you may disagree strongly with me on it, but it is slightly driven by the things that we've said in our journey. You follow the golden threads, you follow the engagement, you follow the engaged clinicians. In some cases, clinicians and services will start to strike up a relationship long before we get to formal collaborations, and sometimes you want to follow those threads, and sometimes you want to challenge those threads. And I think the question you ask in there as well, Nick, is when do you stop and when do you reevaluate? And I think once you start breaching those questions of, I don't have clarity on what our shared objective is, I can't see what you're getting out of this, I don't have trust, there is a question on integrity. Those are the red flags where you say, actually, I need to stop and think about it. But I think there's a pragmatic approach to doing this, because you're correct. Otherwise, you collaborate with everybody and his dog. You follow the enthusiasm, you follow the areas of focus, and you follow those golden threads.
Absolutely. And from what I've seen from some of our industry partners as well, I mean, the real commitment to developing their own value-based healthcare teams, as we have in health, and also the fact that the value-based healthcare academy training is open to health, social care and industry, helps us all to start going on that journey together. I think as we mature, we'll be able to learn from what has worked, what hasn't worked. But I think at the moment, I think we're all very grateful for the industry partners that are happy to come on the journey with us at what is quite still an early stage as we're maturing through this. And I know that other countries are looking at how we're doing this and how we're looking at procurement as well. So we've had a couple of questions come through, so I'm going to grab these up. I've got post-it notes coming at me left, right and centre.
Just before we carry on, it's just for those people who've just joined us, this is the Value in Health Value-Based Healthcast, and we're talking about what is effective collaboration. We're here with Maynard Jones and with Simon Mansfield. Thanks.
No problem. So one of the first questions from the chat, where much of what you are describing is thought leading in the UK, how much are the English and Scottish colleagues keen to visit, listen, learn and benefit from our experiences and reflections around introducing and implementing value-based healthcare? So where's the reach coming from for you guys?
Definitely from Scotland. Obviously, they're devolved, similar to Wales, and I think they are on this journey already. In my national capacity, I've certainly had contact with some of the systems up in Scotland, and they're very keen to embrace. I know that Sally has actually been up in Scotland this week at a conference about person-centred care and realistic medicine. At the ICSs, interestingly, several years ago, they did try to roll out the value-based healthcare, the approach then, the outcomes-based approach across NHS England. And I think because the results weren't coming in quickly enough for government, it kind of died a bit of a death. However, the ICSs, from what I can see, are very much outcome-based, and outcome-driven changes. So they're reinvigorating that. And because they're smaller entities, they may actually develop, and I'd hope to see that they develop some momentum around that. I think when it gets too big, it's very difficult. Wales, as a devolved nation, we're a population of just over 3 million people. Yes, we're kind of complicated in the way that we're split ourselves up. But for us in Hywel Dda, even though we're a small population, we've got the complexities within that. But I think it's when you get too big, it gets very difficult. But it also goes back to, on a tangent, what you mentioned earlier, Simon, and Dee, you did as well. The targets, and until we change the way that planning is incentivized, at national level, we're not really going to get any sustainable change at the local level. So that does need to shift. That is, I believe, shifting in Wales. There's definitely interest from the bottom up in Scotland, and I think from beginnings at the top down as well. And as I said, the ICSs, they're still quite new. So it'll be interesting to see what happens really with them over the next couple of years.
And then, and then also how each ICS is pegged against others, and what that is. And that's all about the use of data. So if we just think about all nations, so in England, obviously there's GIRFT, and you were mentioning there about the size of the scope. And the thing that GIRFT has done really quite remarkably is he said, well, let's have a data focus and let's not rank. And let's just learn about our data in comparison to others. And that really brought everybody to the table. So everybody said no and was scared of it. And so if you got teams that you would never have thought would have collaborated, who were then collaborating around the data, say, yeah, we want to learn. And I think so. I think the potential and the motives then around collaboration, and I think you brought up shared values and it's shared outcomes. And as soon as you start to talk about that, not about leadership, and I liked what you said about the equipoise of, well, let's go into the room and say we don't know what the right answer is, and let's collect the data and then find out. And I really like what you said there.
The data is not the answer, though, is it? The data allows
No.
you to ask the right questions, and I
Yes.
think that's the key thing. We expect the data just to give us the solutions, but I think if we can just get past that and then as that collaborative, whatever it is, then we start to dig in and ask the right questions. That's why we need it, and that's why it's so important. And then we get to the solutions.
Yes, and with everybody engaged then.
Yes.
Yeah.
And what you say there, Nick, I think leads on to the next question that's in the chat, because the primary challenge in the primary secondary interface is the use of data and the perceived use of data for performance management, when actually the truth is we just want to understand our population better.
Yes.
How do we understand our population? And if we go in apropos of nothing, just to understand our population, then that's how we collaborate, rather than we're going to collect this data and then we're going to performance manage you on it.
I think it's very difficult, isn't it, when we think about the landscape of healthcare, when we're trying to push things upstream and ask primary care and community care to do more and more. Maybe they're not always seeing the benefits because they're being seen in secondary care. So how do we actually collaborate and bring the win-win for everybody that brings them to the table when it's not the people at the table that might see the benefits?
That's a really interesting question, Dee, and one that I've talked to several people about. Just before I joined this meeting, I was speaking to a member of our senior team, and in primary care we call it the death by 1,000 cuts, and how work just keeps shifting left, but the resource doesn't follow. But equally, we need to move to a place where we've got primary care data on the table to start informing the work that we're doing as well. And I know that across the ICSs in England and NHS England are working with a company to look at that and actually to demonstrate the value of actually having that primary care data. It allows them a vehicle and language to support that resource shift, whereas I don't think we're there quite yet in Wales. And when we focus, we've talked a lot about PROMS data, data capture, but it really, in essence, the way that we're structured in Wales at present is we can't really start collecting that data at the start of patients' journeys. We start collecting it once they've passed go and once they've passed almost referral into the secondary care system. And unless we start accessing that from much earlier on, we're not going to be able to see the impact of maybe really shifting resources. So I think the primary care element of that data lake really is a missing link for us. And I know there are a lot of people working on this, but I think again that probably goes back to trust, developing that shared vision that this is not going to mean additionality for primary care, but this is going to support them. So there's a bit of work to be done there, I think.
We're talking in sort of quite abstracted terms, and I just wondered if we could just center it around, can you give an example of where there has been effective collaboration, where perhaps you didn't feel it was going to start off, and what steered you then back in the course? Because collaboration probably is one of the most difficult things that we do, because we all believe we're right, we all want to lead, and I think these are just natural things. Can you give us an example that sort of just shows this in context?
I'm trying to think. I wonder whether the heart failure example, Simon, and some of the work we did around the early pathway there. So, and I know there's been a lot of work done in Cwmtaf as well, Dee, with you in heart failure, and it's popping up a lot now. And some of the early work that we done was, just process map that pathway and understand actually the high value, low value interventions, and understanding the access to BMP testing, which is can really support diagnosis. wasn't really available across our system, and there was a real bottleneck. And of course, whenever there's a bottleneck from primary care will try and, you know, circumvent and go to the lower value, high cost echo, you know, was working with people. And I know, Simon, you might want to come in here, because I know that you worked with blood sciences and got them to try and better understand the impact of actually increasing capacity within just a small part of that patient's journey could release a lot of resource elsewhere and be better for patients. But I think it's making sure the right people are in the room, but, you know, getting that data to understand actually who it is that we need in the room. So it was always a problem for primary care, and it was a headache as well for secondary care colleagues and cardiologists with their incredibly long lists of patients waiting for echoes, and the harm that was coming to patients, that actually seemingly one simple change, you know, and resourcing it adequately could really improve for everybody. But that, you know, Simon, you might want to come in there, because I know that you were heavily involved in some of that work, or whether you have another example.
Thank you, Mina. And yeah, the example is a really good one, and it's individual parts of the system doing what they believe is right, and what they're being instructed to do by the system and targeted to do by the system. I think value allows us to collaborate across the different pillars of any system, and to see the oddities that happen. But what I wanted to do was to share an example, and I'm going to wind the clock back a fair few years, more than I care to mention, to collaboration, and it was my personal journey of self-discovery around collaboration. And I used to be, for my sins, the directorate manager of pathology in Princess of Wales Hospital in Bridgend, and it was my first operational management role. And I walked in and I was asked to transform pathology. It was described by our finance director as being untouched by management hand at the time. And I walked in on day one to a performance review with the formidable Paul Williams, who gave and asked no quarter, and he certainly showed me what it was to take a beating in those meetings on my first week. So it was definitely a challenge, and I went in with a load of preconceived ideas. I'm a lean Six Sigma green belt. I'm a Prince practitioner. I'm going to walk in. I've got all of these ideas. I know how to fix this. I was arrogant, and I was centered on my own ego. And I walked in and I undertook a collaborative exercise to tick a box. And we sat down and we did an Ishikawa fishbone diagram. And I got all the post-its up on the wall. I did it just so that people felt they were listened to. I will confess that I did it as a checkbox exercise. And one of the things up there was from our band 2 admin assistant, who said, well, all of our blood samples from GPs are coming in at 2 o'clock in the afternoon, and they come in one go, and there's a huge pile, and we don't have the admin staff to deal with it. If we start an hour later and finish an hour later, a couple of us, we can fix it. All of the ills in pathology, and it was profound. On average, we were not performing 1,500 blood tests every day. They were holding over. Some of them, these are non-repeatable tests. We fixed it instantly by the suggestion of a band 2 staff member on a post-it note and a fishbone diagram, and that taught me humility, because all of the things that I'd planned to do wouldn't have made a blind bit of difference, and it was a band 2 staff member who fixed it all. And I made sure she got credit for it as well, because and it was used as an exemplar by our then director of finance as to here's how you fix things. So collaboration is more powerful than you could ever believe, and I've seen it up close and personal, and it saved my skin.
I think that's a great example of it coming from the bottom up, the same as with our patients and our service users and everything else. I think that leads us nicely, Simon, into some discussion around how do we actually collaborate internally in the NHS, because historically we're not always that good on it. I mean, you touched on it, it wasn't developed in my backyard, so I'm not going to touch it. And I've said a few times, actually, the one thing I absolutely love about the value-based healthcare world is our openness to share and learn. We recognise we're all trying to solve the same problems. We're all going through the journey. Some are in our different maturity points than others. But there is a real openness. And for some, that's great. And for others, that's really scary and frightening, especially at a time when we're all fighting for the same finances or funding awards, when we're all trying to deal with the backlog, and as you say, it's head down, and our chance for absorptive capacity is minimal. You know, we're all trying to get the job done in the hours that we've got. What do you think are some of the challenges internally in the NHS, and how can we start to overcome them? You spoke about some of the ways that you've been doing that in your presentation, but what would be your top tips for broaching the topic of value-based healthcare in a new sort of clinical field?
Don't call it value-based healthcare for a start. I think but language is key, isn't it?
Yeah.
You know, and we call it that, and it's basically a toolkit, isn't it? You know, of various different processes to support you to do things differently. And you know, calling it that can be very, very off-putting, because it is, as Simon said, it's the next new thing, isn't it? The new shiny thing. I think it's about actually how do we improve, how do we work to improve, you know, outcomes for our patients? You know, so again, bring it back to the language of what we're trying to do ultimately, all of us in healthcare, to simplify it really, and then, you know, you bring out the tools when people are ready to listen and ready to engage. And you know, as Simon's, you know, beautifully demonstrated, the solutions often lie within. You know, so giving people time and space, because often, you know, they have them and they get disillusioned because they don't get listened to, and then they just carry on. So I think, you know, it's that time to build relationships, to build trust, and to not come in with the next shiny thing. You talked about kind of, you know, collaborating across maybe organisations, and you're right, you know, but we are preaching to the converted, aren't we, within the value-based healthcare world? But how do you go beyond that? And I think it is, again, using the language of the patient, which is what we're all, that's the common denominator for me, and it's the one thing that actually allows people to leave their suitcase at the door, because that's the one common goal.
For me, you know, so what you have really eloquently described is sort of is a flat leadership, and you know, so leadership comes into collaboration as well, because it provides some direction, but everybody should have that opportunity to lead and steer the team. And you know, so I think and then by having, you know, we talked about the agenda for change, banding, and you know, the level of influence of everyone, and it comes then to co-design, which I think is what you're referring to as well. And then so that the people that we haven't talked about in this is the patients, and where are they in the discussions, and where should we bring them in with collaboration, so it's not another box ticking exercise. So
it's a really good point, and we often roll them in too late. You know, I spoke to a very good colleague from third sector across Wales, and early on in my journey and the national role, and you know, to her, collaboration is about everybody being on the bus at the same time. And I think if you are going to collaborate with patients, you have to bring them in at that first point. And that's often difficult to do. We've got organisations in Wales to support us with, you know, when it comes to service change. We've got the Llais now, or the Voice, which was the All Community Health Council. You have got collaborations, you know, and you've got third sector that can advocate for lived experience voice. But I know that, you know, nationally we are looking into bringing the patient voice, the lived experience voice, into national, you know, clinical discussions and strategic discussions as well. More locally, it's often very difficult to do, but it's incredibly powerful when you see, you know, the impact of having that patient voice. Actually, no, this is what it means for me. I know with the cardiac work we have actually brought patients in, and I know with the chronic pain work we have as well, and with the MSK work, and you know, I'm naming but a few, but for me it's right at the start.
Perfect. Yes.
Simon, and then I've got a question from our audience. So
yeah, I think it's really important, isn't it? And at the end of the day, everything we do is subservient to better patient outcomes, better sustainable patient outcomes for our population. That is what we're here for. That is the objective. and understanding what it means to our population, and it's more than just patients. It's before they become patients as well. It is our population. It is the most powerful thing there is, and it's the question I used to dread when I first started in value-based healthcare. You'd say to somebody, "Oh, I work in healthcare," and they say, "What's your job title?" You say, "I'm head of value-based healthcare," and they said, "Oh, that's interesting. What's value-based healthcare?" And then you'd go into this long spiel of trying to justify what it is. The answer is perilously simple. It's just making it better, and doing it in the best possible way. And interestingly enough, and kind of winding back to your question around how this is perceived in other parts of the UK, I'm actually doing a presentation to a community in Plymouth in the next month or so, and it contains community leaders, members of the public, as well as healthcare professionals and medical students. And the purpose of that is to try and describe it in simple enough terms so it means something to everybody. And the format of that is it's a points to ponder session, where we put it out there and see what people feel about it. And does it make sense? Does it resonate? Can you see how this is the best way we can deliver healthcare? And it's incumbent upon us, if we're asking our patients and our population to complete patient-reported outcome measures, that we actually listen to them and do something with it, and show them that we're doing it. This is where action is all important. Is you said this? Let's talk about this thing that's most important to you. Your anxiety and depression is off the scale, or you're struggling to sleep at night because of the pain. Let's talk about that. That's how we make it real.
And when in this do you bring up the fact that there is no more money in the system? So and then how do you bring that up in your point of collaboration? Because I all the time, I'm hearing, well, we just need this extra resource. Okay, but how's that going to happen?
Yeah, scarce. The whole tenet of value is hinged upon the management of scarce resources. That there will come a point where they are absolutely finite, and we will reach the end of the resources that we can call upon, be they financial or human, and we need to work out the best ways of using those resources to greatest effect. Healthcare is effectively a bottomless pit. You could throw money at it and forever. It's almost infinite. So the question is, if we have fixed financial resources as a way of measuring some of the things that we do, how do we use those resources to best effect? And it's about doing more of the high value things and less of the low value things. And in some cases, there's a timing issue with this as well. And we don't want to get into the 1 year pilot cycle. We want to prove it properly. How do we prove a concept properly and get the science behind it to say that this is going to make a difference, and it allows us to use our resources more effectively? And I can tell our finance director that this will make a difference.
But isn't that's quite a difficult conversation, though, because when you say, well, we're going to get rid of low value, then there are people who are doing that piece of work and they're not going to give it up because that's what they do. And so how do you tell them that they're low value? And this comes back to the collaboration, because every human interaction is a point of collaboration, really, isn't it? And so how do we have those difficult conversations which really underpin value in the sphere of having everybody in the room?
It's not there's no easy answer to it, but the roundabout money, I think you have to be open and honest and transparent about it right from the get-go. I think it is important. Money is historically been an ugly word in healthcare, and I think we're doing our patients and our population a disservice by not being transparent. And actually, that if we are transparent about it, then we can look at it. I mean, we budget ourselves, don't we? We look at our supermarket, bills every week, and heating bills, and we manage that accordingly. And actually, to think that our that our healthcare providers and who we're providing healthcare for cannot think like that about healthcare, I think we are doing them a disservice. So, not that that's necessarily an answer, but I do think it's important to actually not focus on the money, but I think we need to bring that into early discussions when we're looking at transformation, when we're looking at pathway changes, and when we're looking at actually how do we do the best with what we've got. We've got a fixed envelope, So what are the things that we can switch off and actually bring those people that you're absolutely right, people get wedded to what they're doing, and it can often be part of their identity what they're doing. So to get them to not do it challenges so much more than just the thing that we're getting them to stop. There's all that behavioral change that goes around that, so it's not simple.
And I think that brings us back to some of the questions that have come through is, when do we start these collaboration discussions? Who do we bring to the table, and at what point do we bring them? And I think that honesty is, how do we raise the awareness of the public as a partner and as not as someone as we're telling? So if we're very open about the situation and we listen to what it is that makes a difference to the patients' lives and what their expectations are, they can actually start to think of their expectations within the realms of what is the reality of what we can actually afford to do, but also help us with some of those discussions. And we've been doing that with some of our alcohol liaison patients, when we've really been looking at our patient-centred care project. What is it they want? What made a difference? What was horrific for them that they really don't want us to do any more of? And they know that the money is tight, and these discussions are really welcomed. And the fact that they can have their say right at the beginning, they can help us develop leaflets that are going to actually reach out to patients instead of be shoved in a handbag or left on a side. So I think there's many things that we can do. We've had another question on, how do you think we could educate the public more on value-based healthcare whilst not using the terminology, whilst not going along the line of here we go again? Just as we're wrapping up now, what do we think are the last few key messages as to how do we bring our citizens and our patients and our other collaborators on the journey with us without them necessarily knowing they're on the value-based healthcare train?
It's a good question. I think there's something about, sharing data with patients, owning their own data, allowing them and empowering them to have very different conversations with their clinicians and care providers. That then becomes the value, the language of value, doesn't it? So you don't have to call it value-based healthcare. That is ultimately what we are trying to achieve.
Yeah, for me, it's we don't need to talk about value. We can just talk about redistribution of resource to improve access and outcome, and that includes for people who don't conventionally are within medicine. And we know that the population you mentioned, chronic pain, has been poorly served for so long. And how does that then come into the debate and the collaboration? And I think I know that our next topic, and this is just a little advert for next month, and I think it's the 26th of May, we're talking about evidence-based medicine, and what we've not included is collaboration with academia. And do you have some quick thoughts about that?
Yeah, we've got loads of collaborations. We work our university partnerships quite hard. So we've got a joint professorial appointments in some of our hospitals. We're working with PhD students, looking at big data, looking at technology, looking at machine learning, artificial intelligence, health economics. It's really important that we leverage all parts of the system, and it's a question of bandwidth. And the more bandwidth we have, that we can create, the more we can look outwards, and the more that we can get our heads up off that running track in front of us.
So one last question to end up on for each of us. It's come from the audience. So for each of us, if we could change one thing about the implementation and adoption of value-based healthcare in Wales, what would it be? So Mania, I'm going to come to you first, and then Simon,
no pressure,
and then you,
then.
Nick. No pressure.
One thing for me would be changing those volumetric targets nationally, so that they are outcome based, and so then they then get translated into planning cycles.
Fantastic. Simon?
I'm assuming this is like a magic wand thing.
Yeah, this is a magic wand. If you could change the one thing, what was it going to be?
I could change one thing. I'd take egos out of the picture.
Fantastic. And Nick?
Yeah, so I was going to say, which kind of does that, is if you find the common values, why are we here? What are we doing? And we're talking not about our population. Is that sort of veil of ignorance? Is if we were to think about everybody, who would we be thinking about and best serving? Brilliant. What a fantastic session.
My final one would be the language, I think, that goes through all of this. So if we had each of our 4 best wishes here, I think we could actually get somewhere. So Yeah, so thank you so much for joining us. It's been brilliant being with you here today.
Oh, Dee, no, it's brilliant. Really enjoyed this. And I think if we would just, for me, if I was just to sum up, you know, on the consciousness curve, I think we've moved beyond the Glasgow coma scale. I think we're alive and breathing. I think it's fantastic.
Brilliant.
Dee?
Yeah, well, thank you everybody for joining us. Absolutely topic that's close to our hearts. We hope that you'll tune in again soon. Thank you both for your insightfulness and your openness today, Simon and Munir. Thank you everyone for joining us, and we'll see everybody again soon.
Thank you very much.
Thank you.